Hi, good morning, everyone. Welcome to Pediatric Grand Rounds. I want to say a special welcome to some of our retirees who made it out today. Sally Southard and Dr. Althouse, thank you. Today's speaker is Dr. Henry Dodd, one of our soon-to-be graduating third-year residents. Dr. Dodd trained at University of Tennessee Health Sciences, has been at Carilion for the last 3 years, where he's been recognized not only for his clinical care, but for his compassionate and humanistic approach to medicine. He was twice inducted into the Arnold P. Gold Humanism Honor Society. Today, he will be speaking to us about mental health issues in primary care. On graduation, he plans to move back to Corinth, Tennessee. Mississippi.
But it's on the state line.
It's on the state line, yes. We just had a conversation about this. With his 3 beautiful children and his very lazy dog named Precious. Dr. Dodd.
Hope everybody can hear me okay. If you can't, we'll just kind of adjust on the fly. We're not going to spend 5 minutes getting all the levels right. Appreciate that warm introduction. And my wife always jokes, and, you know, nothing against the great state of Mississippi, but I was born in Tennessee. It's my home. You know, if it weren't for Tennessee, Texas would probably be part of Mexico and, you know, lots of other really bad things. So I'm proud to be a Tennessean, and I'm glad that I'm going to at least be close in proximity. But I am excited about moving back and serving those patients there, and especially being close to parents. And I was telling Dr. Althouse that one of the big reasons we're moving back, not only is it a great job, but, you know, my parents and my siblings live there. And so I'm hoping that they'll pull their weight in caring for their grandkids as much as they say they will, because otherwise that was one of the fringe benefits that I was really hoping to enjoy. So today I'm going to try to cover what's a really broad topic, and as you'll see as we'll get into my objectives, that I'm going to narrow it down a little bit to try to focus, and then I'm going to also talk about some things that are not my objectives that perhaps would be a good thing for other residents or attendings to cover. So as I was researching articles with Dr. Liebesny, one of the things I noticed about some of the psychiatry journals is they would often include different quotes and things, and this is not unique to psychiatry. But I thought this one from, you know, Mr. William Shakespeare from The Winter's Tale. I was not familiar with this despite my excellent Mississippi high school education. This quote says, "I would there were no age between." Now, keep in mind, this is the shepherd is entering the scene here as the sailor who's being chased by a bear away from the play is happening. So, "I would there were no age between 10 and 3 and 20, or that youth would sleep out the rest. For there's nothing in the between but getting wenches with child, wronging the ancientry, stealing and fighting. Hark you now, would any but these boiled brains of 19 and 2 and 20 hunt this weather?" So I think that's a pretty good encapsulation for how some of us at times feel when we're treating our adolescent patients. We feel like, why would anybody want to work with these children? There's really not a whole lot of good. In fact, they should probably just be put to sleep is the gist of it. So the objectives that were listed on the email, and here again, is we're going to look at the prevalence of anxiety and depression, specifically in the adolescent population. We're going to look at barriers to diagnosis, treatment, follow-up. We're going to look at some, some new and verified approaches for both improved screening and access. We're going to look at different opportunities for quality improvement and advocacy. And then we're going to propose a practical algorithm for how you might deal with either an acute health crisis or just patients in your practice that you feel would benefit from mental health services. So not objectives. We are not going to review the effects of digital media usage and screen time on adolescent wellness. There are a lot of studies on that, and there was one interesting one that basically said 0 screen time or an hour was about the same, but then above that it started to change quite a bit. Despite my wife's protest, we are not going to explore the effects of social media on mental health and physical health. I think that that's just a little too early, and what I would encourage you to do is think of social media, especially for the older folks who just are like, what are these kids doing? Because I'm getting there, too. There's things where I'm like, that doesn't make any sense anymore. So I know I'm getting older, but think of it as a tool. Think of it as something that can be wielded for good or bad rather than trying to just squash it out completely. We are not going to discuss any pharmacological therapies, and we're not going to look at substance use or misuse. Those are all just too broad for this particular topic. This graphic right here from the CDC website is really what pushed me to want to explore this topic a little bit more. You can see the top graph, and I blocked out the other ages so as not to scare anyone who might be older than 34. The top 10 leading causes of death by age group, and then I cut those off further just to the top 5. And as you can see there, I'm going to use my mouse so that everyone at home. In 2007, ages 10 to 14, you would think that 180 suicides is quite a lot. But then when you look and you see that 10 years later, that's increased by nearly threefold, up to 517, while things like malignant neoplasms, congenital anomalies have all stayed relatively the same. You have to wonder, why is that? And is that not just kind of, I don't know, it just really kind of put me in a place. I had to take a step back. And furthermore, suicide has crept up to be the number 2 amongst the 15 to 24 and even the 25 to 34. So clearly, this is not just an adult problem. This is not just something that we can, kick the can down the road and say, well, this isn't affecting our patients. It's clearly affecting our patients. So I think it's important that we realize that there are 10 to 14-year-olds in this country taking their own lives for a variety of reasons, and we're the ones that are making the most contact with them. So, and I forgot to say, I have no relevant financial disclosures, and as far as I know, Dr. Liebesny does not either. It would have been reported to Janie. So mental health facts and their impact. So of the nearly 75 million children in the United States, 1/4 to 1/5 of those have had a psychiatric disorder. So when you look at your patient panel today, you have 30 patients. You can do the math and think, how many of these patients that I'm seeing today for something other than a mental health disorder either have or have had a psychiatric disorder. And then this statistic right here, of the children that go on to develop, or adults that develop a chronic mental illness, half of them begin by age 14. So again, this is not an adult problem. This is something that's starting and manifesting much earlier. And then 3/4 of those that go on to have chronic mental illness develop it by age 24. So again, these are kids all within our striking distance. This is not as surprising, but 70% of youth in the juvenile justice systems have had at least one mental health condition, and at least 1 out of 5 live with a serious mental illness. And I'm sure that being incarcerated or in jail does not help that. And then the other, a few more sobering facts, and then we'll move on a little bit more to talk about specific prevalence, is that just over half of these children, ages 8 to 15, have received any services. And the average delay, this is average, is 8 to 10 years. So we're clearly not doing as well as we could do. So what are the most common psychiatric disorders? I think we all are aware that ADHD, disruptive behaviors, mood behavior disorders are very prevalent. They're in your face. You see them. The kids running around your office throwing stuff. They get sent home for hitting people. But how often do we see kids sent home for either sulking or worrying that they're crying a lot more just for really minor things, or wow, every time I go by their desk, they jump, they're very anxious. It's rare that kids are sent home for these things, or that parents will seek care for children that are doing this. So I think it's easy to see this graphic and see that anxiety disorders are, even without severe impairment, are affecting a large percentage. And this is specifically from data pulled, and it was actually a little bit older, it's 2010, but it was a national survey face-to-face of adolescents 13 to 18. And then age of onset of these types of disorders. This is the other really scary thing to me, is that the average age of onset is actually quite young for kids with anxiety disorders. And again, this is median age, meaning some kids are starting with some of these symptoms and problems a little bit earlier. And to be quite frank with you, I don't have a whole lot of good news as far as helping us be able to identify some of those things in a really standardized way. But what I want to do over this talk is give you some encouragement and some ideas about how you can identify those things, in particular patients in your community. And then, of course, age 13 is the median onset of mood disorders. So when we look at the prevalence of depression, again, this is pulling from that national survey on comorbid factors and mental health. A little over 1 in 10, age 12 to 17, have had at least one major depressive episode. So again, on your panel of 30 patients that you see today, 3 of those patients have had a major depressive episode at least once. And then of those, 1 of those has had severe impairment with that. The prevalence of major depressive episodes is higher among adolescent females at nearly 20%, but still males are not immune to this. And approximately 3 out of 5 adolescents with a major depressive episode never receive treatment. And you contrast that with adults. It's nearly 2/3 of adults that actually get some sort of treatment for these. So really, again, kids are, a second thought once again, and we know that as pediatricians better than anybody. When you look at anxiety, again, nearly 1/3 of adolescents have had any anxiety disorder. And again, almost 10% of those have had some sort of severe impairment with that. And then, of course, the prevalence is higher in females still, but Males is much higher than that 6% that you saw with the depression, and it's fairly similar across the age groups. But again, I will go back to the statistics because when I saw that graphic, it startled me to think that the median age of onset, my daughters are 4, almost 5. I'm sure you can think of other nieces or nephews or children in your life and think about a 6-year-old struggling with anxiety and that not being addressed and how that can have effects later in life. So, what are we to do? How big of a problem is this? I think this graphic is really easy to just look and see that yellow part, nearly half, are estimated to have a diagnosable mental illness. But then you look at that really small blue part, and it says, 7.4% of children in the U.S. have had any mental health visits this year. Now, granted, some of those issues might be addressed at a primary care visit or somewhere else. But again, only a small percentage of these children are actually getting any sort of attention to this. So why is this? What are some of these barriers, and why can these parents not get their kids where they need to go? So some barriers are naturally, they're just in denial. Parents don't want to think that, little Johnny or little Susie, apologies to anybody named Johnny or Susie, those are just really easy names to say, that they have a mental health diagnosis. That's for older people. That's for people that are broken. That's for somebody else. That's not for my kids, right? So they're just in denial. Or similar to that, there's a cultural stigma, and I think we've all seen that. We're very fortunate here to serve a very diverse patient population. There's a lot of people that have come here from other countries, and while you go out into the county, it's a bit more homogenous. Within Roanoke proper, we have the opportunity to serve a wide variety of people, and different cultures handle mental health in different ways. And quite frankly, there's just a shortage of mental health providers. If you look at this data from 2016, at that point in time, there were a little over 8,000 practicing child and adolescent psychiatry, and if they extrapolated, they said, we're going to need a little more than 12,000 people to really meet the need by 2020. Here we are in 2019. And they anticipated that they were only going to have 9,000. So that means there's about similar to pediatric neurology, similar to some of our other specialties, there is a need. And we can't be experts on everything, but we can certainly be that front line and help figure out who needs to go where. You add to that naturally there's going to be longer wait times when there are not as many providers to help take care. And then, of course, the cost associated with it. The cost to get in to see a specialist, copay, depending on your insurance, can be quite high. The cost of taking time off of work to actually travel there, and I'll get into that in just a moment. So naturally, looking at barriers due to poverty. Again, children less than 18 are disproportionately affected by poverty. We know this, and that's by virtue of the fact that most kids don't have jobs. They're looking at somebody else for their financial support. So while those kids only make up, about a fifth of the population, a third of those, they represent a third of those that are in poverty. And for pediatrics as a whole, I know we can look at our bank accounts, and we're not hurting, but less than 5% of the total health care spending is spent in pediatrics and in that area specifically. While whites represent a larger group of the patients that are poor, Hispanics and African Americans were 3 times more likely to be poor as compared to white and Asian children. So it's not equal across different neighborhoods. And then among the children that were experiencing poverty and actually needed care, you're talking less than 1 in 5, less than 15% are receiving services, and even fewer complete treatment. But there's more barriers than just that. Like I talked about, where I'm moving back to, it's a decent-sized town, about 25,000. But we're going to be serving, similar to Southwest Virginia here, a large population that has to travel quite a ways to get to the big city, right? So these families in these rural areas, they have to travel very long distances, and the weather affects things like that. And clinic hours don't always accommodate that. There are some places that will stay open to 5:30 or 6, but, if you're working, short-term work and you don't have protection from different government programs to say, okay, you can't be fired for taking off time to care for your kids, or they just have low-paying jobs and the flexibility is minimal. They can't get child care. There's lots of reasons why, even though parents may know that their children need help, they can't get that. And in pediatrics, there was an interesting study that was published, and they presented providers with basically similar kids with similar diagnoses, similar HPI. But then they presented their social history part, and they presented lower socioeconomic status, kind of median, and then high. And every one of those, and just looking at those cases, said that the ones with the lower socioeconomic status were more likely. They said, oh, that kid probably has severe mental illness. So, again, we can check our biases at the door, but at the end of the day, it's difficult to divorce the human being from the physician. It's a task that we all have to struggle with every day. But we need to be aware that there are barriers, both created by other people and sometimes created by ourselves. And then there's barriers due to business. Again, we're cutting through some very thin lines here. But simply put, and I've noticed this on my rotations, the slots, the primary care and mental health treatments, they just have different structure. They have different goals. And the reason for that is the problems are different. Some take a little bit longer to tease out, whereas I can, sit a kid down in the chair and, do PFTs and then give them a bronchodilator and see how they respond to that. I can get a pretty immediate result. But in just a few therapy sessions, I'm not going to be able to tell exactly what kind of effects I'm having on this stuff. So you have these short, often unscheduled visits, right? Oh, I stubbed my toe, or I cut myself and I need to come into the doctor. That's easy to do for an acute care visit, but I witnessed something very tragic happen, and I'm in crisis right now. You're not often going to get that 15-minute slot or that 10-minute slot that you're going to get at the primary care doctor isn't going to be able to adequately address that hurt or that pain, that mental anguish that you're feeling from what you witnessed. So it's just different. Many children, unfortunately, are not going to meet criteria for a specific diagnosis, and I think that's where a lot of us have difficulty with it. They meet some of the options for depression, but not all of them. Or, they seem like an anxious kid, and I screened them, but they're not really anxious. What do I do with that? And even if I did determine that they had an illness, well, how am I going to treat that? Okay. I was going to hit approve. So glad you told me. Positive mood. Let's go. The inability to identify social determinants, such as either parental mental health problems, food and housing insecurity. You think about it. You see a kid come in and you think, man, they're in really bad shape. But then you don't have the ability or the time in that visit to look and say, oh, this parent, and now sometimes we'll see this, especially when you have a little bit longer, but, this kid appears to have a mental health disorder because the parent is schizophrenic or they're bipolar or they're severe splitting. So a lot of these things are very difficult to tease out just because of the time that we have and the way that our clinics are structured. And quite frankly, like Dr. Vance pointed out last week in his grand rounds, there's just a limited focus on mental wellness. We look at things that we can do to identify mental illness, but we don't always look at the things that we can do to promote mental wellness. And it's very simple. We tell patients to stop smoking, right? And we talk about all the benefits that come from that. But we don't talk about how treating their mental health disorders and then adding those positive factors can help, cure right along the same time that we're treating their mental health disorder. I will tell you this person's name, but I'll give you a golden star at a later date if anybody knows who this person is. I think you got it, Chuck Yeager. Yeah, he's a handsome fella. And if anybody's looking for a baby name, I think Glennis could be a boy or a girl name. That's what he named his plane. He named it after his wife, Clamorous Glennis. And the reason I want to bring this up, Chuck Yeager was he's allegedly recorded the first person to break the sound barrier, go above Mach 1 in a linear flight. USA, right? So basically, Chuck Yeager, this was shortly after World War II, or around that time, they were able to achieve breaking the sound barrier with ballistic missiles and through nosedives. And the reason this was important is because warfare was changing, and these planes that they were making were basically they were trying to push the limits further and further of what they could do, how far they could fly, how quickly they could get there. A lot of these planes were just disintegrating, and they couldn't figure it out. They would try tweaking things here and there, but nothing was really working. So the USA agreed to, with the British Air Force, to kind of pull their data together. Well, what ended up happening is we basically stole all their data and didn't give them any help, and we kind of took some of their things, and we got close enough and figured it out. But the point is that a lot of these test pilots were pretty brave. A lot of them died. But the reason that this is, I think that this, when we talk about breaking these barriers, is these are some brave individuals that were kind of in uncharted territory. But what they did is they used a lot of their resources around them to figure out ways, okay, I'm having some difficulty in keeping things stable over here while I deal with this. How can I make this better? So, they tweaked the cone design. They tweaked the tail. They tweaked the wings. And eventually they got to the point where breaking the sound barrier was no problem. So I think we're kind of at that point in mental health care in the United States and figuring out what is it that we can do to kind of keep things stable, because I know that all of us feel like we get a foothold at times on something, and we feel that we're really getting some traction, then we kind of get pushed off our base because something over here that we haven't been giving attention to has basically caused us to fall apart. We kind of have to start all over again. And a lot of that's because we're doing it ourselves. So I'm sorry, I know church is on Sunday typically, but I didn't mean to preach this morning. But I think this is important to this, and I'm really excited. So prevention is really kind of step zero, right? Usually you teach kids to start at 1. I've tried to teach my kids to start at 0. Doesn't always work. But early intervention, catching things before they get worse, right? And that's a challenge. But that's kind of using your gut instinct there when you see some of these kids come into your office. And just I literally took this from Dr. Mann's slides. Promoting a positive mental health by identifying and highlighting things that help kids flourish, right? So loving supports, parental attachment, family ties, any mentors, helping kids establish routines, praising their skills. Man, did you make that? You're really good at that. That's awesome. I haven't seen anything like that. Helping kids get involved in structured activities, making sure that at school that they're connected, that they're going to school. And then, praising them for their sense of humor, right, or when they do kind things. Just any of these things that we can harp on, even if it takes, 30 seconds, I think that can be worth more than some of the interventions and things that we blab on about in primary care clinic that could make the difference for a kid. So let's look at just a practical framework of how this might be. So I'm going to posit that in addition to step 0, right, which is prevention, right, that would be nice. If you don't have to fly a plane and break the sound barrier, you can walk and get there, right? It's going to take longer. But there are times where we're going to have to fly, right? So establishing strong family and community focus. It doesn't matter what we get up here and talk about or what we think. And I know if Dr. Mullinaire was here, I think he's listening, and if he's not, it's okay. But he will tell you that when they would go to Malawi and they would go to these other places, and, over here stateside, we would have an idea, and we would say, we're going to raise this money, we're going to buy this, or we're going to come up with this, and we're going to send that over there. And he told me one particular story about a group of individuals. I don't remember exactly what it was, but for the sake of the story, you're going to understand the analogy. They basically came up with this really complex system of how they were going to communicate with each other and do all these different things, and they took it to them, and they were really excited. And the people there said, Dr. Mueller, this is really nice, but that's not what we need. This is what we need. So he told me that he learned a really good lesson from that, and that is you can assume that you know the needs of individuals. You can gather all the data that you want, but every one of us that goes to a different community is going to have to be in our community, and we're going to have to be talking to the parents, talking to the community boards, and say, what is it that is affecting our kids? What is it that they need? Because it's going to look really good on your resume, and it's going to look really good for the news story. But if it's not going to enact a real change in that community, I would say that you're wasting your time. And you could even go with tantamount to say, oh, well, you're kind of really focusing on the wrong things, and that might be detrimental to the community. And then professional collaboration, right? I can't know everything. That's why we have these grand rounds. Medicine's a lifelong learning pursuit. So professional collaboration is no stranger to us. But I do feel like at times that child and adolescent psychiatry is a bit on an island. In fact, we put them in a different building over here. Dr. Dunsmore, I don't know if she's here. I haven't seen her. But we need a children's hospital, right? We need an area where we can all sit. Thank you. We need an area where we can all be together and we can take kids down the hallway and do that warm handoff and say, oh, have you met Johnny? Johnny, this is so-and-so. He or she is a counselor, yada, yada, yada. That professional collaboration makes a huge difference in the stats I'm about to present. And then that goes along with the infrastructure and scaling. Once you get these things in place, the economies of scale are difficult to get up higher if you have everything in place on the front end. And then measuring the quality. We wouldn't be doing a good job or a service to ourselves if after gathering all this data and implementing these changes, we didn't look to see, is this having a positive effect or not? And that's all QI. So intervention in primary care. What you want to do in all the literature I've seen, and there's we're going to talk about a toolkit from the American Academy of Pediatrics that they've published specifically, and then a position paper by child and adolescent psychiatry from 2015, where they talked about in primary care and in specialty services specifically what can be done to help make sure that no kids are left behind, basically. So developing that safety net, I can see kids in continuity clinic and get to know their families, but unless I get them plugged into the care coordinator or somebody else who's able to identify what some of those family needs are, I'm not going to know that family isn't able to communicate via phone because mom or dad lost their job and now they don't have communication. But if you have a safety net in place and you have ways to ensure that those types of issues don't prevent you from providing care, that can really go a long way, and that's kind of in step with prevention. And then identifying the correct therapeutic target. Again, like I said, in kids it's tough because half these kids aren't going to meet specific criteria. And furthermore, we've done a wonderful job over at Jefferson and other clinics screening mothers for depression and anxiety. And the facts are the facts. 7% of infants or young children live with severely depressed mothers. And that's not a safe, stable, healthy environment for these children or for that mom. And so us being able to identify that, not saying, well, that's OB-GYN's problem, right? No, that's everybody's problem. So what is our role as providers? Like I said, if you go to the American Academy of Pediatrics webpage, they had put together a task force. And there's more than just this toolkit in place. So this toolkit has a pretty lengthy document. I'm just going to include part of it so you can see. But basically they go through and they look at all the different screening tools because, quite frankly, screening is complicated. I don't know about you guys, but it's like alphabet soup. I just get lost in, wait, PHQ, SDQ, and you know, what am I going to screen and how am I going to screen it, right? You know, half the times these patients come in and there's a clipboard sitting over there. You don't know if it's from the last patient or what they wrote on there. What are you going to do with these results? Are they going to be scanned in or are you going to type them in the chart? And then are these results even applicable, right? We've been using the screening tool, but has anybody looked to see if it's verified or if there's anything better? So to that point, PHQ, SDQ, PSC, there was actually one study from that pediatrics article that talked about the positive predictive value is actually 50% or less, depending when you look at just well-child visits, right? But one thing that they did point out the strength of is that for parents specifically and PCPs, it can kind of help normalize some of these things, right? So we talked about those cultural stigmas. So providing parents a screening that says, hey, look, I ask this to all of my patients, right? Those are things that we learn in medical school about how to ask some of these very challenging questions. So it'll help focus visits. So whether it's on a clipboard, there was one study that looked at a web-based pre-visit, and the parents really like that, right? Because when you got 3 kids and you're juggling everything, you're trying to fill out those papers. If you've already done that on the front end, you as a provider can already pull that into your note, and then you can remind them, oh, you said this was a problem. Oh, yeah, thank you. I would have forgotten about that. And then my dream is this geolocation text services, right? So when you sit in the waiting room and you get a text message, it's like, oh, your appointment's da-da-da-da-da. But we're not there yet, but that would be pretty awesome. But the most important thing for screening is it has to be universal, right? So we have to be able to compare across ourselves. It has to be confidential, and it has to be focused on what the patients and the parents want. And you have to talk to them about why you're doing that screening and what it is, because otherwise they're not going to understand or really care to answer those questions, and they're likely to either put all zeros or all fives. None of us have ever done that on a survey ever, right? So no matter how I tried to pull this in, it always came up a little bit blurry. But this is one page out of this, 20-page PDF from that AAP health toolkit. And you can see there it talks about things like bright futures, heads. These are all things that we kind of do during our HBI portion. But you can see there it looks at the tool, how many items are in that tool, the age group that it serves, right? Because some of these are not verified for kids less than 8, or some of them are not verified for really kids at all. It's more the parent. And then how long is it going to take you to either give that, or how long is it going to take you to score that, right? And you can quickly see how these 15-minute visits get chewed up pretty quick. And then you want to look at, are there any language requirements, right? Some of these are translated into multiple languages. And then some of them are free, some of them are not. So I guess I'm telling you, here's the tools. I don't know what your practice is going to need one day, and I apologize. But here's where you can go to find out, I'm worried about this in my patient. I'm seeing a lot of anxiety. What screener do I want to do? One of the screeners that I was not familiar with was this SCARED screener, the Screen for Child Anxiety and Related Disorders. And basically it's a bunch of descriptions of feelings and behaviors, which are easy for kids sometimes to understand. But when they're a little more concrete in their thinking, sometimes you have to have the parent or somebody else kind of explain that to them. And they rank it from not true to very true. And this total score is going to give you an idea of whether or not they're suffering from an anxiety disorder and their specific subgroups. The only thing it really doesn't touch on is either obsessive-compulsive disorder or post-traumatic stress disorder. But I felt remiss if I didn't at least include one screener that maybe you had or had not seen before, just to be aware that this is an example of one of the things. You know, I think we've all heard of PHQ-2 or PHQ-9 and other screeners, but I thought this one, it's easy to remember SCARED. You know, kids scared, they're afraid. You know, what can the GME do, or what has the GME been doing? And I think that we've been doing a lot of that here, and that's encouraging electives in child and adolescent psychiatry. And in fact, it's a requirement here. We do 1 month of inpatient, 1 month of outpatient. And I think that's unique, but I think it's going to become more prevalent. This is one of those statistics from the studies, but basically pediatric residents who complete a psych rotation report greater confidence in providing mental health care. Taking advantage of opportunities on other rotations, right? I know that we've all been in the emergency department at some point in our lives, and depending on where you practice, some places will have kind of a mental health area where, it's like the walls are padded and all the stuff that is for it. And unfortunately, those rooms in our pediatric ED are often full of kids waiting to be placed in inpatient facilities. So, you can take a day and say, hey, I really like to focus on this. And then, of course, just old didactics, case-based learning, making sure that that's part of the curriculum is going to help improve confidence. And then some other fun buzzwords, collaboration and co-location. We consult people all the time, right? And Dr. Dodd, I know, hey, this kid's doing some weird stuff. I want to consult for a test and treat, right? And then it's like, I'll be saying, and, maybe I'll get a note back. I know I will get a note back from Dr. Dodd, but one of those things where it's very, this is black, this is white, this is here, this is there, right? There's no kind of back and forth, right? Because that's his realm. But, we have a limited number of psychiatrists and psychologists. So the models that have worked really well, and if you look in our adolescent clinic, there is this co-location, right? There's psychologists in the clinic where they can go down the hallway and say, hey, that thing we were talking about and how it's been affecting your sleep, right? And you're just kind of nervous all the time. I think that's the result of this based on these screeners, and I really think that you would benefit from not only this medicine that's going to start, but also I would really like you to meet with this person because, cognitive behavioral therapy has been shown with medicine together to be more efficacious. And with a shared EMR, that obviously makes things a lot easier. And time's going to be limited to either these urban or academic areas, but it doesn't mean that it has to be. We can build these things out in other ways. And then, of course, collaboration, having the right office staff, case managers, identifying the hurdle, having huddles at the beginning of the day to identify, okay, hey, guys, remember this patient, every time they come in, they've been really unkempt, disheveled, they smell bad. I'm really worried that they're experiencing homelessness. What can we do for this rather than saying, they need to find somebody else. So everybody's going to kind of be on the same page and be looking for those things the more you talk about it. One of the things that I couldn't find as much data on, but I did want to just at least put out there so you knew that I at least looked at it, is the role of telehealth, right? It makes a lot of sense, right? Everybody has the ability to pull out a phone and video conference someone in a variety of ways, and we've even done that here. And it seems like a pipe dream, right, for, okay, well, a lot of what they do, they don't really examine the patients. They sit there and talk to them, right? So telehealth should be great. But there are multiples of these, and I think these pass legislation because it does seem easy. It's like, okay, here's some money. Go buy this video equipment, and then they can talk. It's called Project ECHO, the Extension for Community Healthcare Outcomes. And basically it's a model for telehealth and rural care. There's about 18 states that have passed legislation like this. But to me, it's kind of a dead end. It's like, building a dormitory but not earmarking any funds to keep the maintenance up, right? So part of the goal in using that equipment is not only for consultation but to train the providers via teleconferencing and or to discuss complex patients. So, again, multiple states have versions, and legislation has been aimed at that to expand it nationally. But a lot of this technology is expensive, and it's rapidly changing. So I'm not saying that it can't be done, but I want you to exercise caution in thinking that it's just a cure-all, that it's gonna fix everything. All right, so you click refer in the EMR, you're done, right? Well, it's great, but it's like I said, it's not a panacea. So it's kind of counterintuitive, but this one study in particular looked at 3 different locations in like Vermont, New York, and Pennsylvania, and they were basically looking at these already established clinics, some that had case managers, some that did not, and basically they just employed a student social health. And in these interviews, they would identify a patient, like I said, that was either anxious or depressed or whatnot, and they would kind of assess whether or not they were ready for treatment. And it wasn't really defined what treatment readiness was, but essentially they wouldn't schedule these kids for appointment until they kind of said, yeah, I'm ready. Because what was happening is they were getting discouraged because their numbers would be a first-time show rate of 10%. Because it's easy to click refer and say, I'm scheduling this patient for an appointment, and then they no-show. But basically what they did is they kind of they retooled their resources. So we're not going to waste time, even though it's on these kids. If they're not ready today, we will schedule a time when the social worker can call them back and assess where they are. And you guys know, like anything else, like in business, when have you put something in your shopping cart on the internet and you put in your email and then they email you, hey, you didn't finish your purchase, right? It's that second time that they call you that sometimes you're like, okay, I am ready now, right? So lo and behold, this works in medicine in the same way it does everywhere else. So I think we need to think a little bit differently sometimes as to what's going to be effective. And then, of course, part of those phone calls was motivational interviewing to say, hey, what are the, you know, I can tell that you're not really wanting to reschedule. Sounds like there's not a good time for you. What are the barriers to that? Is it transportation? Because we can help with that, right? So training your staff, training other people to be able to do that. And then, of course, measuring progress. None of this really matters or helps if we can't measure how good we're doing, right? So the frequency of that initial use, the compliance of appointments, are the patients actually having success from these treatments, or are we not really helping them at all? And then, you know, we need to measure, are we adequately getting reimbursed? Are we just, you know, depending on if you're a nonprofit or a for-profit, are we just, you know, basically throwing money out the window? So to that point, I think that a part of this that probably doesn't want to be talked about because it would appear that we're being greedy, but the providers and the other care managers do need to be paid for their time. And right now, there's not CPT codes or other things for, you know, time that you may spend caring for a chronic patient or reviewing literature or talking to specialists, but those are coming down the pipeline, and they have been introduced in some medical home type systems. You know, allowing PCPs to bill for their services. Like sometimes they might deny it and say, that's not under your purview. But we need to change it and say, actually, you know, dealing with psychiatric issues is under my purview as a PCP. And then, you know, times where you may interview the parents alone without the child, or you might talk to a child and adolescent psychiatrist without the patient present, getting reimbursed for those times. All those things are going to help. So when we try to put all these things together, again, screening is a big part of it, and then knowing which specific screens to do depending on the population. You know, triage and referral to the appropriate behavioral health treatment. If you have an acutely suicidal patient in your office, that's not the time to try to schedule them for follow-up, and we all know that. That's common sense, right? They're going to go to the emergency department. You're going to kind of call the crisis hotline. You're going to do everything you can. But knowing what is severe and what is able to be managed in your office is important. Having access to either child and adolescent psychiatry, either via consultation on demand, like being able to pick up a phone and call, or face-to-face, just going down the hallway and being able to talk about that. And I'm going to get to something shortly about how we can improve that. And then just care coordination, right? Things that we already do a pretty good job of, but that we could do better. So Massachusetts, one of our 50 states, they, I don't know why that was funny, but I didn't mean for it to be. But anyways, 33% of, they did a survey of children in this state, and they found that a third of the parents had responded that they had waited a year more for an appointment with a pediatric mental health provider. And that half of those, they said, you know, the pediatrician really never asked me about my child's mental health. And then over 3/4 reported that the pediatrician wasn't really helpful in getting them in touch with resources. And if I saw that data, I would be pretty sad and upset. Well, somebody was so sad, they actually filed a class action lawsuit against, on the behalf of the Medicaid children, citing serious emotional disturbances, a state of emergency, if you will, a real one. And the key issue was lack of access to community-based mental health services, right? And as a result of that, they passed legislation that said you will pay this amount of money per child in order to administer standardized, age-appropriate behavioral health screening. Not only that, we will create a program that has different geographical hubs housed with child and adolescent psychiatrists who are available by consultation from 9 to 5. They will call you back within 30 minutes to an hour, right? And then if it's on the weekends or another time, it will be within 24 hours. And then furthermore, they kind of convinced, I don't know how they convinced, but I'm sure there were some backdoor deals, but they convinced the private insurers to also contribute a certain amount of dollars. It ended up being like $2.50 per child in that state, which to me seems like a really low bar, but I know the dollars stack up. But, you know, why should we reinvent the wheel? This model, which was originally developed in Massachusetts, provided training for providers, right, via teleconferencing and other things. They would assist with referrals. You're closer to this area, go here. Don't go across the state. And then they had that telephone line, that warm line that they connect with somebody and discuss these diagnostic limits. You know, I'm worried about this kid, and I'm trying to figure out, could I just go ahead and start them on an SSRI? Or is this going to be a little more complicated, right, because there's some visual hallucinations that go along with this. And that's where having their expertise is helpful. There's this website, the nncpap.org, and it's as you can see there. It's basically a directory of all the states that have existing programs. Now, currently Virginia and some other states around here, I think North Carolina does have one, and the District of Columbia does. But these are programs specifically modeled after this that basically have these geographical hubs. They have this one line, and they have applied for grants and received funding for this. So I know that Richmond received some funds from the Human Resources that was providing the same grants for this, but it's not statewide yet. As we're getting close to wrapping up here, I wanted to talk about one of my heroes in pediatrics to make a point, and that is Dr. Bob Sanders of Tennessee. All right, Andrew, you can go 2 for 2. Anybody know who Bob Sanders is and why he is so famous in pediatrics? So Bob Sanders was, if you get on the AAP website, they have all these crazy things, but they, some older guy did some older physician that was a contemporary of him, a little bit older, did an oral history with Bob Sanders, because Bob Sanders was a coroner. He was a pediatrician, and he was a coroner in Middle Tennessee. And basically, he said, I'm getting tired of signing these death certificates for these kids in automobile accidents. This was back in 1960. He was just getting really frustrated with that, and he thought, this is an area where I can enact some change. So in 1965, or 1966, the National Traffic and Motor Vehicle Safety Act mandated seatbelts in every car. That's just crazy to me that there were never seatbelts in cars. But in any event, that's the way it was. But furthermore, it wasn't until 1977, after many years of petitioning both local and state legislation, that kids less than 4 should be restrained in automobiles. And Tennessee was the first state to pass such legislation. Initially, it was voted down, but the next year it passed with some caveats. But it took another 8 years for all states to pass comparable laws. So Dr. Sanders was a very, he was a humble man, a very simple man, but he really got fired up about this, and his wife even remarks on the oral history, like, it really changed him. He got fired up. So you look at the effect that it had: motor vehicle crash deaths, children younger than 13, 1,384 in 1975, cut in half by 2014, and then infants less than 1, cut in 3/4. Now, again, we know that car seats are installed. They're not always installed correctly. That's a whole other talk. But the point is that Dr. Sanders saw what was affecting the kids in his community, and he worked to enact a change for that. So I feel that we have a generation's worth of work ahead of us as primary care pediatricians. And just very briefly, I want to talk about how I believe that we can do that. The communities, along with the physicians, need to identify, like I said, and say, what are our goals? What is it that we want to change? The specialists and the agencies, they can provide that framework and the tools, and we need to use those. And we need to use the ones that are going to work in our communities. We might have to modify certain systems, right? So we might not be able to have 10 and 15-minute appointments. We might have to have a 30 or a 60-minute slot here and there. It's going to eat into our bottom line. But if we're going to be able to have time to address these needs, we're going to have to change our systems to accommodate that. And then we're going to have to study the effects of our interventions and see if it's worthwhile doing or if we need to try something different. And then we need to act and continually re-engage the patients and the community to see if what we're doing is correct. I mean, primary care is primary. We should be equipped to manage the mild and moderate behavioral needs of all kids. We shouldn't be punting that to child and adolescent psychiatrists. We should be the ones that are going to handle that, because we have first contact with these kids. They already know us. We have their trust and comfort. We know the context of the symptoms that they're presenting with, and that might be due to mom's mental health or dad's mental health versus this is actually in the kid. And there's really no increased stigma when going to the primary care doctor that you're already going to. So these are a list of my references. I want to knock out these CME questions, and I'll give everybody an opportunity to ask questions. I appreciate your patience. So in regards to the types of mental health disorders in children, which has the earliest median age of onset? Substance abuse, mood disorders, ADHD, or anxiety? Anxiety disorders. Still scares me. And then use of the screen for child and anxiety-related disorders, SCARED, helps identify all of the following subsets except panic disorder, generalized anxiety, separation anxiety, social anxiety, post-traumatic stress disorder. Got it, post-traumatic stress. All right. Any questions?
Questions or comments in the room? All right. Thanks for that talk, Henry. So I'm a specialist. As you were preparing this talk, what is the role of the specialist in assessing patients for mental health problems? What should we be doing?
Yeah. Again, certain specialists are going to have a little more time in their clinic at times, but I think like I said, we're all kind of primary care physicians first. The bulk of our training is to prepare us to be primary care physicians. So I think there are certain aspects of that we lose. But I think the ability to look at a patient's family and identify that there might be some barriers to them coming to appointments, there might be some barriers to them following through on the care, and that might be a symptom of a larger problem. Specifically what a specialist can do is, what I think we can do is change the framework to allow you guys to be able to do more. Like right now, over in that community building, you don't have as many resources as if you were in a facility that had all the specialties available, where you could go down the hallway or say, hey, I want you to go down to the second floor and go talk to this person. I've already sent them an in-basket message. Telling somebody to go across town, hop on a bus or go park somewhere else is not going to work. So actually having co-location of those services is important. And then if you don't, and you're a specialist who's off somewhere, for specialists, a lot of times you guys are going to be in larger urban and academic settings. So for you guys, that's what I think is going to be the most helpful. If you were a specialist somewhere else, I would say knowing which one of these regional hubs was close to you, if your state had it, and being able to call that warm telephone line and say, hey, I've got this kid here. I know that I'm a geneticist, but I'm worried that they might be suffering from depression, and I just don't have the resources in my office to care for it. Where can I send them? Or contacting the PCP. I think that's really about all you can do as a specialist.
I just had a comment. This is Dr. Dudley in psychology, and I noticed that Dr. Mitchell is here as well, and appreciate that you're bringing up the co-location model, which is definitely wonderful in the adolescent clinic. You're right. We're able to do that quite easily. But I feel like that's a wonderful model, and also appreciate the integrated model where that's really ideal, where you're in the clinic of that primary care. And maybe you mentioned if Dr. Dunsmore's listening, that would be a plug for having more psychologists, if possible, that could go into the primary care. And then ideally, like you said, we would have our own hospital where it's just down the, we're all co-located, and it's just a matter of being down the hallway. I think that's where you're going to get a lot of bang for the buck is those two models, the the co-location and the integrated versus the collaborative, which we try to do, which is difficult. And then I think what we typically do is not so much collaboration as it's more, here, I sent you this referral, let me know how it goes, and then I send you a quick, email back, and that's it. It's just much nicer for the patient to have all of that coordinated and in one area if possible. Thank you for bringing those topics up.
Absolutely. All right. Any other questions or comments in the room? Oh. Test the length of the cord.
Good job, Henry. It's not a question. It's more of a comment. I find as a primary care physician referring my patients for evaluations to psychology or even child development, I find it very frustrating that I don't get the note is blocked for me. So the patient comes in a month later, I cannot see anything except maybe the medication that they're on. I don't quite understand how, as a primary care physician who referred the patient to you for the evaluation, I'm blocked from seeing the details of the note. I don't think that's in the spirit of collaboration and actually adequate patient care.
Yeah, in fact, it might take one of those lawsuits, right, to bring to light the fact that just doesn't make any sense, right? And so I agree with you that it can be quite frustrating. And if the tables were turned, if you will, I don't think that would fly. So I think it's important to know everything about that patient, especially being the one referring them. Okay. And I don't have an answer for that or know anything in literature that discuss that.
This is Hannah Smith. Henry, you mentioned the Massachusetts model with the regional hubs and creating a warm handoff. I don't think it was addressed in this beginning, but Virginia is working on that as well right now. The Virginia chapter of the AAP is setting up hubs at the moment. Southwest Virginia is going to be one of those. We don't have anybody on the hub yet, but we're going to be putting in place one of those consult lines where eventually 8 to 5, a PCP's office can call directly and consult about the kid in their office. And then several online and in-person education options for primary care providers, where it's either a monthly WebEx where you can get a short didactic and some case discussions, or an in-person weekend with like a monthly tailor, sort of like a mini residency in mental health as well. So Scott and I are helping is a stretch for me. I'm just the networker. But if you have questions on that, I'd love to talk to people to hook you up with the people in charge of that program.
Thank you. All right, any other questions in the room? We've got time.
Just a comment on that. We're actively kind of seeking interest for people who might want to be a part of the hub as we get set it up for Southwest Virginia. So care coordinators, pediatricians, psychiatrists, and psychologists that would be interested, just if you could get in touch with me.
Dr. Keel, do you have an email that you would like people to?
Yeah, R.S. Keel, K-E-E-L, the different spelling Keel than all the other Keels in the hospital, at Carilion Clinic, K-E-E-L.
All right. So we have a few more minutes, so I can unmute the phones. So if you are on the line and you do not want to ask a question or make a comment, please just place your phone on mute now.
The conference is now in talk mode.
Now we got a new lady doing our voiceovers. Does anyone on the line have a question or want to make a comment really quick? You answered all their questions.
Thanks, guys.
All right. Thank you very much, sir.